Philadelphia International Medicine, PIM, provides international patients and physicians with access to an unmatched network of world-renowned doctors, surgeons, and hospitals that deliver personalized medical, surgical, and rehabilitative care ranked among the best in the world. Since 1999, Philadelphia International Medicine has helped patients and physicians from around the globe eliminate the guesswork, planning, and anxiety of finding and connecting with doctors and hospitals ranked among the best in the world. With 8 hospitals, 2 medical schools, 2 cancer centers, and hundreds of top doctors, only PIM can bring you into its medical family with one easy phone call or email. Thanks for joining our presentation. Philadelphia International Medicine's Global Education Media Program is a monthly digital platform that invites physicians from around the world to exchange knowledge and innovative uses of medical technology, review the latest advancements in research and clinical care, and share best practices in case reviews. To contact our presenter, refer a patient, or more information, email physicians@philadelphiamedicine.com. Follow PIM's YouTube channel for more educational videos.
Hello, good morning, everybody who's joining us here. My name is Enrique Aradillas. I am by training an internal medicine doctor. I did a full internal medicine residency in New York City. Then I also became a neurologist. I did a neurology residency at Drexel University here in Philadelphia. And finally, I did an extra fellowship in interventional pain management at Penn State. And today, we're going to talk about pain. And actually, the name of the talk was Chronic Neuropathic Pain, Diagnosis and Treatment. But just earlier this week, as I was revising it and updating it, I decided to change the name from neuropathic to just chronic pain. And hopefully by the end of the presentation, you'll understand why. So first, I'd like to say that I have nothing to disclose. I have no conflict of interest. I have really nothing. I'm just a simple doctor. So first, there are, as you know, all sorts of definitions and descriptions and whatnot. So the International Association for the Study of Pain decided to define pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or describing terms of such damage. I would add to this that chronic pain is not a curable condition. Chronic pain is only a treatable condition. This is something that I teach or that I try to explain to my patients so that they understand the whole reason for the treatment and the basically everything we do here at the Vincera Institute. So they used to be, and these 3 subclasses of pain, nociceptive, inflammatory, and pathological pain, were described almost 20 years ago. Nowadays, this classification doesn't really apply. Thanks to research, we know now that this is quite not correct. But back then, they described nociceptive pain as pain that comes from stimulation of a peripheral nerve and then responds only to stimuli approaching or exceeding harmful intensity. And then it may be classified according to the mode of the stimulation. And this type of pain is what you get when you break a leg, when you have a bad back, arthritis, or a muscle sprain, a tendon that is severe, or when you're having a heart attack. This would be nociceptive pain. Then back then, they described inflammatory pain as the pain that is associated with tissue damage and the infiltrations of immune cells. This actually, it is nowadays, it is known to happen with any kind of nociceptive input. There's always the activation of the immune system, but we'll get to that. And finally, they had a third class of pain called pathological pain, which it was described as the kind of pain that arises after the pain itself had reached a disease state that was caused by damage to the nervous system. And again, this is an old classification of pain, but it is still used nowadays, let's say officially. But the current trend is to classify pain only into nociceptive or neuropathic pain. So nociceptive pain is what we saw before. It is the kind of pain that is caused by stimulation of a peripheral nerve fiber. The specific type of nerve fibers that can detect painful input are basically just two types. Unmyelinated small C fibers, which are less than 1 micron, or thinly myelinated A delta fibers, which are 1 to 4 microns. And neuropathic pain. This is a new concept. Well, new in the sense that it has only been around for the last probably 10 years. But it is described as the kind of pain that comes from a direct injury to the nervous system, whether the peripheral nervous system or the central nervous system. Now, what is important is that both can become chronic. And the mechanism for this chronicity involves permanent changes in the peripheral and central nervous system neurons that actually come as a response to the normal pain transmission mechanism. So what's important to understand is that chronic pain, it is not supposed to be the norm. You're supposed to have pain acutely, and then once the nociceptive input has decreased, then the pain should go away. When it becomes chronic, nowadays, it appears that you need these plastic changes to be sort of out of control. And they happen to become out of control or to get out of control from the normal mechanisms to feel pain. So you develop chronic pain from the normal ways that you develop or that you actually feel regular pain, so to speak. So now why? In chronic pain, why do people or patients or humans develop chronic pain? Who will develop chronic pain and how does it happen? We know some about how it happens, and we also know something about how the process keeps going, but it is not clear why only some patients develop it. And it's really now impossible to predict who may develop chronic pain. There are some trends in the immune research or the immune aspect of chronic pain, in which it appears to be that in order for you to develop chronic pain, there must be a propensity, or your immune system is prone to develop an autoimmune disease. So there's a link between that and chronic pain, but it's not clear yet. So we'll go over today the mechanism on how you develop and how you maintain chronic pain. We'll try to identify these patients. I'll try to go over the whatever is out there to properly treat this pain, these pain patients. And I'm going to try to also go over what is the latest research ongoing. So before we get into that, I want to clarify some concepts that have haunted me ever since I started to treat pain patients. The first one, which is the majority of patients that I get to see here are being already diagnosed with, is complex regional pain syndrome. It used to be known as reflex sympathetic dystrophy. Fibromyalgia is also a very popular diagnosis. Myofascial pain syndrome is becoming also more and more popular, and failed back surgery syndrome. See, they all share the same mechanism. They all started out with a nociceptive or neuropathic pain input, but they became chronic. So in the clinical point of view, it is irrelevant to encase a patient with this CRPS diagnosis, fibromyalgia diagnosis, myofascial pain syndrome, failed back surgery syndrome. Ultimately, they all share the same mechanism for them to have developed into a chronic pain state. So ultimately, in the clinical, or from a clinical point of view, it doesn't matter if you have fibromyalgia or CRPS or myofascial pain syndrome, because ultimately you can treat these patients with in the same way. The problem is that some of these conditions, like fibromyalgia and myofascial pain syndrome, were described by rheumatologists. Complex regional pain syndrome was described by anesthesiologists. Failed back surgery syndrome was described by surgeons. So they tried to give it their own spin. So there's always been this fight between rheumatologists, anesthesiologists, surgeons, and lately neurologists like myself, in trying to unify all these syndromes with one, or probably more than one, but similar mechanisms. So now, how do you develop chronic pain? It appears that there's probably just two major mechanisms. One involves the nervous system, and the other one involves the immune system. Within the nervous system, you have two mechanisms. The first one is called peripheral sensitization mechanism, in which there are changes in the expression of sodium channels following an injury, whether it's nociceptive or neuropathic injury, which results in a hyperexcitability system. Then the process advances to involve not only the peripheral nervous system, but also the central nervous system. And these plastic changes that result, they manifest clinically as something that we call increased gain in pain, which nowadays is being called central sensitization syndrome, actually. So these two would be the neuronal mechanism. The third mechanism, which is necessary and in some cases sufficient to cause chronic pain, is the immunological mechanism, in which there is a sickness-like response that involves interaction between the immune system and the nervous system, peripheral and central nervous system, which results in the activation of glial cells, which are the immune competent cells that live within the nervous system, which also result in an enhanced nociception or enhanced pain system, so to speak. So studies in both animals and humans have shown that these two mechanisms, the neuronal and the immune, they may cause pain individually and in concert. They enhance each other, and both may be caused by nociceptive or neuropathic pain input. An injury, say nociceptive injury, so a patient can fracture their femur, or a patient can develop a neuropathy, which would be an example of a neuropathic pain input. They both can cause the activation of these two neuronal and immune mechanisms, but only the immune mechanism can be triggered by chronic opiate use. So, and this is the main reason why chronic opiate use is not being used anymore to treat patients with any kind of chronic pain, because chronic opiate use can cause itself the activation of the immune mechanism and cause more pain. It is not known how much each one of these contributes to any one patient's condition, but regardless of the inciting event, any new or ongoing pain generator will enhance or sort of perpetuate the patient's condition by maintaining these mechanisms. Now, the one thing about the immune mechanism it appears to be needed for the development of chronic pain. So if you do not activate the immune system, you do not develop chronic pain. And this is important in terms of treatment. Now, it is known that you need to treat both the mechanism, neuronal and immune, along with any possible pain generator that may be present in any one patient. Now, if you have any question, please ask. Don't be afraid of interrupting me. So we're going to talk a little bit about the peripheral sensitization, which, remember, this is the normal way in which any human feels pain. So peripheral sensitization is the reduction in threshold in an increase in responsiveness of the peripheral ends of nociceptors. So these small fibers. And then these high threshold peripheral sensory neurons transfer input from the peripheral targets, skin, joints, muscles, the viscera, etc., through peripheral nerves into the nervous system. So this is the regular way anybody feels any kind of pain. Then when peripheral sensitization starts to occur, this contributes to the pain hypersensitivity that is found at the site of the tissue damage and inflammation. A good example of this is when you get a sunburn and afterwards you feel your skin is warm, is red, and things that shouldn't hurt, like the shower feels like it's burning under the sunburned areas. So this is a good example, a sunburn, of how peripheral sensitization translates clinically. But remember that this is the normal way to feel pain. So this is normal up to a certain point. So here you have a graph or a slide in which it's just explaining you have external stimulus, whichever it is, heat, mechanical, or chemical. Say you develop a sunburn, or you break a leg, or you're splashed with acid. These are sensed by these small fibers, and the sodium channels create an action potential, and is transmitted back into the central nervous system, where it's expressed as pain. Then what starts to happen in the peripheral nervous system, in the peripheral nerve, is that it starts to activate sodium channels. So they develop a lower threshold to open. So you now develop pain from things that shouldn't cause pain, like touch opens these sodium channels, or heat opens these sodium channels that before they had a higher threshold to open, a higher voltage threshold to open. Now it's lowered, so now you feel pain with other stimulus that should not cause pain. And lastly, there is an increase in gene expression that is coming from the dorsal root ganglion nerve cell body, which is triggered by the release of substance P and brain-derived nerve growth factor, among others. And eventually, when that starts to happen, this increased gene expression becomes a permanent change in the peripheral nerve. Now, let's talk about, that was a little bit of a really fast explanation of what is or how peripheral sensitization happens. Now remember, this is the normal way in which you feel pain. Eventually, when these external stimulus heals, all of these voltage, the sodium channels go back to normal, these genes stop to be expressed, and everything goes back to the way it was. Except when it doesn't, and you develop chronic pain. So in order to develop central sensitization, we know some things that have to happen. We know, for example, that the injury have to be strong enough to elicit a 50 to 200 hertz of an activation of a C and the A delta fibers to induce central sensitization. The noxious stimulus must be intense, repeated, and sustained. Now, this intensity, it is subjectively evaluated. Because for me, for example, I'm afraid of needles. So if they stick a needle in me, I would feel the worst pain of my life. But there are other people that do not feel that kind of pain as intense. So this intensity is very subjective. So this is how you can develop pain or chronic pain from a needle placement, a vaccine placement, or things that are not painful in general, but if that particular patient sensed it as intense, they can develop chronic pain from it. It has to be repeated and sustained. And apparently, input from many fibers is required over dozens of seconds. This stimulation causes the early immediate response in gene expression at the dorsal root ganglion neuron. There's synthesis of new proteins, brain-derived neurogrowth factor, calcitonin G-related peptides, substance P, which serve as two neurotransmitters for pain when it advances into the spinal cord. But it also gets transported back into the site of injury, where what happens is they stimulate the production of new sodium channels. And these new sodium channels, like I said before, have a lower voltage threshold to fire. So when these sodium channels are being expressed, it triggers an ectopic or spontaneous firing of the dorsal root ganglion near the cell body, or what is called the axon hillock. So this, once we get into the central nervous system, you can see this is the presynaptic membrane, where you have this brain-derived neurogrowth factor, glutamate, substance P, and calcitonin gene-related peptide, or CGRP. Each one of these neurotransmitters has a receptor on the postsynaptic membrane. You have mGlu receptors, which are receptors for glutamate, B2 receptors, which are receptors for substance P and CGRP, neurokinin 1 receptors, TRK-B receptors, CGRP specialized receptors, and NMDA receptors, which were the first ones to be described when the researchers found this central sensitization mechanism. So glutamate, like I said, it binds to GLU-R receptors, GLU-R2 receptors, AMPA receptors, and NMDA receptors. Substance P attaches to NK1 receptors. Brain-derived neurogrowth factors attaches to TRK-B, neurokinin 1 receptor, and CGRP1 receptor. CGRP binds to CGRP1 receptor, and nitrous oxide is produced by several types in the spinal cord of cells and can act presynaptically and postsynaptically. So you get the nociceptive input. You break a leg, and these neurotransmitters are released into the synaptic cleft, and they bind to their specific receptor. So remember that this nociceptive input, if you develop peripheral sensitization, will happen now spontaneously and irregardless of if the original injury is healed or not. Once these receptors are stimulated, what happens ultimately is the influx of calcium. And this rapid increase in intracellular calcium activates phosphokinase and MK2 calcium 2 intracellular neurotransmitters that are the two major effectors of central sensitization. These two, phosphokinase and MK calcium 2, what they do is they activate the production of new gene expression and proteins. So ultimately, what this causes, the influx of calcium activates phosphokinase calcium NK2 and phosphokinase A, and they activate ERK1 and 2, which is needed for new gene expression and the production of new proteins that ultimately causes the development of increase in spontaneous activity, the reduction in threshold for activation by peripheral stimulus, and the enlargement of the receptive fields, which translates, as we'll see in a little bit, into certain clinical characteristics that can be tested in the office. So this is how you can develop from a normal physiological mechanism an abnormal response in which now you have central sensitization and peripheral sensitization. So this would be the neuronal mechanism for the development of chronic pain. Now, the immune mechanism involves the activation and recruitment of several different types of immune cells in the area of injury, regardless if it's nociceptive or a neuropathic injury. It also involves the disruption of the blood-nerve barrier, which allows for the invasion of the nerve by fibroblasts, macrophages, and Schwann cells. It also involves the production of these cells of a variety of pro-inflammatory cytokines and chemokines that have been implicated in the generation of neuropathic pain. And they do that either directly sensitizing action on nociceptors or small fibers, or by stimulating the release of agents that can act on neurons and glia in the central nervous system. And once these glial cells, in particular microglia and astrocytes, are activated, they cause, or they're the next step for the central sensitization consolidation, so to speak. So in 2008, it was found that cytokines can induce on their own central sensitization by activating astrocytes and microglia. They increase the excitatory synaptic transmission, they decrease inhibitory synaptic transmission, and they may further induce long-term potentiation through the activation of gene transcription and development of new proteins. And it appears that if you block these pro-inflammatory cytokines, you can effectively suppress central sensitization and alleviate chronic pain. Now, this is just a diagram on how this happens. You have a peripheral injury, then this normal microglia, through the action, in this case of interferon gamma, but you can do this with interleukin 1, interleukin 6, tumor necrosis factor alpha, activate these microglia, and once they're activated, they secrete a number of substances that are known to excite pain transmission neuron, or they also act as reuptake inhibitors of certain neurotransmitters. So here we go. This is a very important slide. When I went to medical school not too long ago, a synapsis was only made by the presynaptic membrane and the postsynaptic membrane. But nowadays, the synapsis, it has 4 parts. You have the presynaptic membrane, the postsynaptic membrane, astrocytes, and microglia. These 2 regulates whatever is seen here. They can stimulate the release of glutamate or its reuptake. They can also activate sodium channels. They can activate the expression of TOL4-like receptors on both the presynaptic and postsynaptic cleft. And they can also dysregulate potassium and calcium channels. Astrocytes can also produce cytokines, chemokines. They can, and they're responsible for the reuptake of glutamate in the synaptic cleft. Once you activate them, actually, you decrease this receptor for glutamate. So glutamate in the synaptic cleft becomes more abundant and continues to stimulate NMDA receptors, AMPA receptors, and all the receptors that we saw before. And this contributes to development of central sensitization and chronic pain. So that was a very summarized view of how these 2 mechanisms, the neuronal and the immune mechanism, are needed for the development of chronic pain. And they both arise from the normal. It's an abnormal response to the normal mechanism of pain transmission. So now when you're in front of a patient, what you need to determine is that, first, is there any neuropathic pain? And remember, neuropathic pain is an injury to the peripheral or central nervous system. So it can be a peripheral nerve. It can be a bunch of peripheral nerves, as in a neuropathy. It can be a lesion to a nerve root, or it can be a lesion to a plexus, the lumbosacral plexus, the brachial plexus, or the cervical plexus. It's important to understand that anybody with an injury to a nerve will develop chronic pain. And treating this central sensitization sometimes is not enough. You also need to treat the injury itself. So this is why it's important to understand and diagnose any neuropathic pain problem on any patient with chronic pain. The other type of pain that needs to be diagnosed and treated is a nociceptive pain. Remember, nociceptive pain is the kind of pain that comes from anything that is not a nervous injury. So a bad knee, a bad back, a bad ankle, a muscle injury, a pinched nerve, arthritis in the spine, anything that can cause ongoing pain from an input from these nociceptive causes needs to be diagnosed on any one patient. And the last thing is that needs to be determined is that if there's any signs of central sensitization or not. Because if there are, then this needs to be treated. A lot of times I get to see patients who have been diagnosed with complex regional pain syndrome on, say, a leg, and what they really have is just a lumbar radiculopathy that with some peripheral sensitization, there were really no signs of central sensitization. And in that case, simple things like an epidural injection or referral for neurosurgery or back surgery is all they need to be to alleviate their pain. And the same thing happens with neuropathic pain injuries. So in order to determine all of those, we need to get a good history and a good physical exam. And within the history, we need, all these 11 attributes of any kind of pain: the onset, the localization, the intensity, the quality, the radiation, associated symptoms, alleviating factors, aggravating, what has been done so far to work up that pain, what therapy has been used, and what is the current therapy, and if it is helping or not. One thing that I came up with is this pain review of systems, which is just basically asking for any systemic manifestations of chronic pain. And they mostly are just what you would see on a patient with an autoimmune disease. So I asked for fatigue, I asked for any weight loss, generalized joint pain, abnormalities in the gastrointestinal system, and abnormalities in the urinary system. And I have found that about 60% of patients with chronic pain will have a positive pain review of systems. Then on the physical exam, the specifics of the pain examination are allodynia, which is described as a non-painful stimulus perceived as painful. Hyperpathia, which is a painful stimulus perceived extra painful. Hyperalgesia, which is described as a painful stimulus that at the beginning it is not evaluated as painful, but once you reach the threshold and you keep on and you repeat the painful stimulus, it is sensed as extra painful. Deep sensitization, it is expressed in the muscles, and it has to do with the activation of large fibers that can transmit pain, which are A-beta fibers. Joint pain, these low threshold mechanoreceptors, which are normally inactive in joints, become active. So by squeezing the joints, especially small joints like in the toes and fingers, can elicit pain. Now, this from 1 through 5 can be seen in peripheral sensitization, like when you burn from sunburn, for example. Things that don't hurt, like touch. Things that should hurt hurt a lot. Sometimes there's some spot on the skin that don't feel until you keep on doing, like with a pinprick. If you squeeze the muscle wherever you're burned, you can feel pain, and sometimes you can also feel pain when you squeeze a joint. Loss of surround inhibition, wind-up phenomenon, and long-term depression are three clinical expressions of central sensitization. So loss of surround inhibition can be tested by stimulating a specific dermatome. Usually when you, for example, stimulate the biceps, which is the dermatome that corresponds to the 6th cervical level, the neurons that are surrounding the neurons that represent C6 usually are inhibitory neurons. When you lose this surround inhibition, the stimulus goes beyond that dermatome. So you stimulate C6 dermatome, and patients not only feel it on the biceps, they can feel it on the triceps, they can feel it up on the C4 dermatome, C6 dermatome down in the forearm. So it is a stimulus that goes beyond the dermatome that is being stimulated. Wind-up phenomenon is the expression of, again, this loss of inhibitory neurons, and it is expressed as an ongoing sensation of pain. So you stimulate a patient with chronic pain with a painful stimulus, and the stimulus goes on for further than 7 seconds. Apparently 7 seconds is the maximum level of, or the maximum number of seconds that you would be able to feel a painful stimulus after it's been applied to you. If you feel it beyond this, then the surrounding neurons that inhibit this are being affected, and it's another expression of central sensitization. And then long-term depression is the clinical expression of a very complicated process in which there is internalization of a special kind of glutamate receptor called AMPA receptor, which it ultimately just translates into wherever the patient feels pain. When you stimulate it, there is no sensation of pain upon a painful stimulus. But this is not as clear-cut as this loss of surround inhibition and wind-up phenomenon, because you can have a peripheral neuropathy that also can be expressed as numbness in that area. But numbness can be two things. Can be a symptom, meaning that the patient feels numb, or it can be a physical exam finding, meaning that when you compare it to other parts, that particular part of the body doesn't feel a particular input. Then within the physical examination, we also need to examine the motor system, the autonomic system, and you need to look for dystrophic changes. And these dystrophic changes are just basically the nails and the hair, the skin in the hair. That's all it refers to. It doesn't refer to muscle atrophy, and it doesn't refer to any other skin changes. It's just the hair in the skin and the nails. All right, now, how to determine if there's neuropathic pain? By history. Well, the Mcgill Pain Index, which was developed in Canada at the Mcgill University a long time ago, in 1975, can tell. It is a measure of pain intensity, but more importantly, it is a measure of the type of pain. And it was developed back then, many years before there was this classification of pain. And it was developed to determine if there was any nociceptive pain, if there was any neuropathic pain, or if there was any, what they called back then, psychological pain. So it is not the total score, it is rather, there's a set 27 questions, and they're divided, and they're specifically designed to ask for nociceptive input of pain, neuropathic input of pain, and what they call back then psychological pain. The Douleur Neuropathic 4, or the DN4, is another pain scale that can tell if there's neuropathic pain or nociceptive pain. And the Boston Neuropathic Pain Scale is also a very good tool to determine that. Then you can determine the onset and the inciting event, and if there's any other major injuries that happen at the onset or that were before. I also always advise to ask the patient to describe their pain, and I ask them if there's any specific pain that is worse than others, and so that I can determine the pain pattern, whether it's a peripheral nerve, peripheral neuropathy, a plexopathy, an injury to a root, or any regional pattern. I think nociceptive pain is a little bit more obvious and simple than neuropathic pain, because I see that most commonly it is facet arthropathy, neck pain, back pain, and lower back pain, sacroiliac joint arthropathy, which is buttock pain, hip joint neuromas, or also something very common, radiculopathy. I would say that if you are 25 years or older and you have lived all your life in planet Earth, you will have some sort of chronic pain from one of these. So, because remember, it is normal to have pain. And up to a certain point, it is normal to develop chronic pain. What is not normal is when there's this maladaptive response to the normal mechanism in which humans feel pain. Now, are there any signs of central sensitization or not, and where they are located? So like I said before, allodynia, hyperalgesia, deep sensitization, joint pain, and hyperpathia can all be seen in peripheral sensitization. Loss of surrounding inhibition, wind-up phenomenon, and this long-term depression with hyperpathia are expression or clinical expression of central sensitization. And it's important, at least for us here at the Vincera Institute, to determine that, because for that, there's only certain things that can treat central sensitization. Hopefully by now the answer should be clear. And it's simple. It's just to determine the chronicity of the pain, determine if there's any neuropathic pain input or nociceptive pain input, and to determine if there's any signs of central sensitization. So that's it, those 4 things. So the next step would be to classify it, if possible, into any of the non-chronic pain symptoms, like, again, CRPS, reflex sympathetic dystrophy, which is the same, they're synonymous, fibromyalgia, myofascial pain syndrome, failed back surgery syndrome, etc. And to do this, you use the rest of the history, associated symptoms and signs, alleviating factors, aggravating factors, what workup has been done so far, past therapy, current therapy, and this pain review of systems. So now, once you've diagnosed any kind of pain, chronic or not, neuropathic or not, nociceptive or not, and once you determine if there's central sensitization or not, for any kind of pain, patients need to be reminded that there's only so many ways to treat pain. And in general, I tell my patients that there's only 6 ways to treat pain. The first way is medications. In any way you want them. You want them orally, through the skin, IV, whatever way, those are medications. Then you have interventional pain management procedures like facet joint injection, facet joint denervation, radiofrequency ablation, epidural injections, transforaminal injections, caudal injections. All of those would be these interventional pain management procedures, which can be done here. We do them either under ultrasound or under X-ray guidance. And then some patients, not all of them, but some patients do need some surgical treatment for the pain, like what we also do here for core muscle injuries, for injuries to the muscles in the abdomen, pelvis, back, etc. Or within the surgical treatment, there's also placement of implantable devices like a spinal cord stimulator or a dorsal root ganglion stimulator or an intrathecal pump, which we also do here at the Vincera Institute. Then the next form of treatment of any kind of pain would involve physical therapy, which we have here, very advanced physical therapy. And next we have pain psychology. And this is not because patients are crazy, It is specialized pain psychologists that help patients with development of cognitive behavioral therapy, coping mechanisms, relaxation techniques, biofeedback, graded motor imagery, transcranial magnetostimulation, electroconvulsive therapy, etc., which we also have here. And the last way to treat pain is something that we developed through research, which would be plasmapheresis, or it's also known as plasma exchange therapy, which is a way to treat the immunological aspect of the pain by filtering the blood and taking all the inflammatory cytokines and proteins, chemokines, and all these inflammatory signals, which has been shown to improve chronic pain conditions, but a specific subtype of chronic pain conditions, not all pain conditions, but a lot of them. And you target the following. Remember, this treatment has to be targeting something. Central sensitization, both the neuronal mechanism and the immune mechanism, and the nociceptive pain input and neuropathic pain input, if any. So far, I think no questions, because I don't really know if anybody has asked any questions so far, but I don't think so. Now, within the medications, we have a whole bunch of them. We have neuronal cell membrane stabilizers. Everybody knows gabapentin or pregabalin. A lot of other doctors also use Tegretol, or a lot of other anti-epileptic medications, selective serotonin reuptake inhibitors, serotonin and norepinephrine reuptake inhibitors, for example, duloxetine, which has been recently approved by the FDA to treat chronic back pain. It's another example of how chronic pain can trigger or can be treated through inhibiting the release of serotonin, which in the spinal cord acts as an inhibitory neurotransmitter. Sympathetic blockers like clonidine and other alpha-1 blockers, muscle relaxants, sodium channel blockers like mexiletine, NMDA receptor blockers like ketamine. Another sodium channel blocker that we use is lidocaine. And there is one other neurokinin 1 receptor blocker, which is very effective in treating the pain that comes from a small fiber neuropathy, but it is used not for that. The original intended use is for nausea, and it's a very, very strong anti-emetic medication that is given mostly for chemotherapy, patients who are receiving chemotherapy. And it's a blocker of neurokinin 1. But if you remember, neurokinin 1 is stimulated by substance P. So really what it's doing is blocking substance P, and the P stands for pain. It's one of the first neurotransmitters that were discovered that act or that help with the transmission of pain. Then you have immunomodulators like thalidomide, lenalidomide, low-dose naltrexone, mycophenolate, mofetil, azathioprine, methotrexate, and we also here use IVIG, intravenous immunoglobulin. And then some examples of interventional management procedure, pain management procedure. You have epidurals, you have sympathetic blocks, trigger point injections, regional anesthesia, peripheral nerve blocks, and we can block any nerve. We can block the lumbosacral plexus. We can block the brachial plexus, the cervical plexus, and its branches, the greater and lesser occipital nerve block. All of these help in treating both the input of nociceptive or neuropathic pain, and by decreasing that input, you also help the central sensitization process. And like I said before, here in Philadelphia, we do ketamine infusions, lidocaine infusions, plasmapheresis or plasma exchange therapy, intravenous immunoglobulin, other immunosuppressive therapy like mycophenolate, azathioprine, methotrexate, and sometimes we use prednisone, but more importantly, we combine these therapies because, like you saw before, ketamine, which is, for example, ketamine, which is an NMDA receptor blocker, or in other words, a glutamate blocker, NMDA receptors are not the only receptors that are involved in the central sensitization process. You also have receptors for substance P, you have receptors for nitrous oxide, you have receptors for brain-derived nerve growth factors. So combination therapy seems to work best for any one patient. And then what we have on research going is, believe it or not, stem cell research has been halted by the FDA because of some concerns of the development of some neoplasms. This research was going on in patients with other conditions like rheumatological conditions, autoimmune conditions, but for now, all this stem cell research is on a hold from the FDA. But there's another way to modulate the immune system. See, the gut and the bacteria in your gut is a major determinant in the activation or not of the immune system. And it has been shown, especially in Australia, that fecal transplant, which is exactly what it sounds like, they clean up your gut and they transplant fecal matter of a donor in order to give you a new microbiota, a new bacteria. It seems to help rheumatological conditions, autoimmune diseases. So this treatment was initially developed for Clostridium difficile colitis, C. diff colitis, and is very effective. But now patients who develop this may also have rheumatological conditions like Sjogren's syndrome, lupus, CREST syndrome, what have you. Some of them may also have multiple sclerosis, myasthenia gravis. And on these patients, it was started to be noted that the fecal transplant would also improve their baseline immunological problem. So there are several studies going on in Australia and South Africa, I think, about the use of this fecal transplant to treat autoimmune conditions. And I know for a fact that in Australia, there is fecal transplant being used to treat the condition known as complex regional pain syndrome, or also known as reflex sympathetic dystrophy. So, any questions so far? No? All right. We're almost done. I have some information on ketamine and the papers that I have been involved, the research that I have been involved with Dr. Schwartzman, Dr. Alexander. And like I said, ketamine is a glutamate receptor, so it blocks NMDA receptors. And it is very effective in treating complex regional pain syndrome. The other medication that we use here, like I said, is IV lidocaine infusions. And we also published a paper on it in 2009 regarding the use of lidocaine intravenously. And we also do that here. Before my time, but also done by my predecessor, there's a paper published in Lenalidomide, which is a variant of thalidomide, which is a very strong immunosuppressive medication in the treatment of CRPS by inhibiting the expression of tumor necrosis factor alpha and other pro-inflammatory cytokines, decreasing the expression of this neurokinin 1 receptor, which, as you remember, it is the receptor used by substance P, and by also decreasing the expression of NMDA and AMPA receptors, which are the receptors for glutamate, through the inhibition of activated glial cells. So when you deactivate glial cells with lenalidomide, you help at least the immunological aspect of chronic pain in patients with CRPS. And thalidomide had also been used for these chronic pain patients back in 2001. And Dr. Schwarzman, my predecessor, also published a paper on it in 2003. Plasmapheresis, which was developed here also as treatment for CRPS, mostly, has also been used, and we still use it to treat some patients that have a more immunological input into their pain than others. And there's a collaboration between us and doctors from England and Turkey, North Italy, and Germany to try to compare plasmapheresis versus intravenous immunoglobulin versus other oral immunosuppressive in the treatment of CRPS. So that's another research that is ongoing. But like I said before, combination therapy seems to be the best. Treatment has to involve the targeting of central sensitization and targeting of any ongoing input of pain, whether it's nociceptive or neuropathic. Now, it appears that the older the patient, the more involved the treatment. And the younger the patient, the easier it is to treat. And this is just simply because of the normal aging process. The normal aging process will involve inevitably the development of chronic pain. That is just the way we are designed. So if at one point in your life this normal pain becomes intractable, what most likely happens is this development of central sensitization. The younger you are, the less of this wear and tear pain input you have. So it does become easier to treat when you develop central sensitization.